Awesome. Good morning, everybody. Sorry for the little delay. Before we begin, I would like to respectfully acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I'm delighted to introduce our speakers today, who are both local. So first of all, Dr. Darren Lau is a general internist and diabetes physician, as well as a clinical epidemiologist at the University Hospital and K Clinic. His primary focus is broadly speaking, measuring and improving the outcomes of diabetes care. This has taken the form of studies to examine and improve the use of newer diabetes medications with heart and kidney benefits, and a randomized trial examining the effectiveness of continuous glucose monitoring, which is what he's going to talk about today. Presently, he holds funding from Alberta Innovates to help deliver and evaluate a novel model of virtual diabetes care tailored for Indigenous rural individuals and communities, a very important area. And then Ms. Tanya Perry is an RN and a diabetic educator. She's a nurse who has specialized in diabetes education for 15 years. She's worked with Royal Alexandra Hospital Diabetes Outpatient Clinic, several Edmonton area diabetes specialists, and a few GPs teaching patients in all areas of diabetes, including pregnancy and insulin pump education. Ms. Perry has contributed to research commentaries concerning the study of exercise in women with type 1 diabetes. More recently, she's been involved in a randomized trial of continuous glucose monitoring and in developing patient education tools. So with that, I will welcome them to speak about continuous glucose monitoring, digital health for adults with type 2 diabetes.
Thank you for that introduction, Dr. Kassam. So as Dr. Kassam said, my name is Darren Lau. I'm with Division of General Internal Medicine. I have a small outpatient practice at K Edmonton Clinic. I'm a fairly small volume prescriber, but I've had the pleasure of seeing referrals from many of you colleagues here today. So it really is an honor to be here at Medicine Grand Rounds talking about continuous glucose monitoring, digital health for adults with type 2 diabetes. I have a co-presenter today. I'd like to let Ms. Tanya Perry give herself a quick introduction. There you are.
Morning. It's nice to be with you guys this morning. Yeah, well, brain fog now, guys. So this is excellent. I just get the opportunity to work with a bunch of different people and do a few different things, and I'm excited to be here with you this morning. Excellent.
All right, let's see. In terms of disclosures, I have no conflicts or competing interests to disclose.
And I have received professional income from a few different companies in dealing with diabetes education.
Now, the primary research being presented here today was not funded or approved by Abbott Laboratories, but some of Tanya's time involved in the trial was invoiced to Abbott Laboratories through a pre-existing community diabetes education program. So this is a program that already existed that we made opportunistic use of. I'm just going to put the acknowledgements up front before we go through objectives. Again, today we're going to be discussing the results of a local randomized clinical trial. And I do have to acknowledge the contributions of others, including co-investigators, Dr. Rose Young and Dr. Donna Manka from the departments of our own department and from Department of Family Medicine, respectively. And of course, the trial would not have been possible without the activities of multiple research assistants, including Ryan Zhang, who's in the audience, just right there. I have to acknowledge some recruitment partners. Doctors Daniel Shafrin and Antonia Barnes actually led a station a research assistant in their clinic for a 2-week period of time, which is kind of nice. And then, of course, we have support from others, so Epicor, ABSPOR-U, University of Alberta Hospital Foundation, and this department. Okay, so today our objectives are fourfold. First, we're going to describe the evidence for CGM, continuous glucose monitoring, in improving outcomes for adults with type 1 and type 2 diabetes. Second, we're going to examine results from a local randomized trial on the use of CGM in adults with type 2 diabetes not on insulin therapy. That would be the majority of adults with diabetes. We're going to apply an approach to CGM to several interesting cases, and then we're going to optimize with tips to approach patients on starting CGM from the Tanya perspective. I think it'd be nice to start by talking a little bit about what continuous glucose monitoring is. CGM is a wearable sensor and transmitter package that measures, records, and transmits glucose levels on a continuous basis. So illustrated here is a typical sensor transmitter package. It's wearable, it's adhered to the skin. There's a filament that comes down here. The filament is located in the interstitial space where the glucose level is actually sensed. The sensing technology is there's different technologies on the market, but the ones that are most common are typically the exact same as you might find in a good old chem strip, glucometer, or finger stick blood poker. It's an electrochemical reaction where glucose oxidase catalyzes oxidation of glucose, and that generates a voltage dependent on the concentration of glucose in the local area, and that magnitude of voltage reflects that and is picked up by the electrode and then transmitted to a reading device, which is either a phone or a dedicated reader. Now, the reason why I go through this is it's important to note that the actual glucose level being sensed is interstitial glucose, and this is different from capillary or venous blood glucose. Venous blood glucose is our usual gold standard for glucose measurement. In practice, the accuracy of these devices compared to venous blood glucose is pretty good, with mean absolute relative difference of about 8 to 9% in the current generation of devices. But there are circumstances where the reading from a CGM might be different from what's going on in venous blood. For example, if glucose levels are changing really quickly, sometimes the sensors might lag behind by a couple of minutes. And that's just an important thing to let patients know about if they're feeling a certain way, but it's not yet picked up on the sensor. Illustrated here are the current sensors on the market. The evolution of them is kind of interesting. So this is the currently available Abbott Freestyle Libre 2 device. And then shortly after Libre 2 came out, Dexcom switched from G6 to G7. So there's the G7 device right there, a little bit smaller than the Libre 2. This is also the G7 device with the over bandage that comes with a package applied to it, just to help it stick a little bit better, last a little bit longer on the skin. And then here is the Libre 3 device, even smaller still. This device is available in the US and in Europe. Hopefully it comes to Canada soon. It is literally the size of 2 stacked pennies. So this is really nice. I won't spend too much on this slide. If you do have any questions about accuracy, we can talk more about this slide or address questions you might have. There are other corner cases where the accuracy of the devices might be a bit off, things like high-dose vitamin C or hydroxyurea patients, but those typically are pretty corner cases. Now, CGM, I want to point out, is not just a replacement for capillary blood glucose or good old finger stick blood glucose measurement. If all patients do is use it as a replacement for capillary blood glucose, I would consider that to be a gross underuse of CGM. I think of capillary blood glucose measurement as a relatively dumb form of measurement. You poke your finger, you get a one-off measurement, and then that's it. But if we think about clinical care, we're often looking at our blood sugars with respect to important thresholds, things like 4.0 for hypoglycemia, above 10.0 for hyperglycemia. And if we imagine 4.0 as a bit of a cliff, okay, so it's fantastic if I'm driving a truck and I know that cliff is nearby. It's fantastic to know my distance away from that cliff, my current blood sugar of 6.5. But it would also be good to know what direction I'm traveling in. Am I moving away from that cliff or towards that cliff? And it would be good to know how quickly I'm moving. These additional pieces of information, I think, would be very material to how I choose to drive my truck. And that's what CGM provides. So this is a screen capture from the Dexcom Clarity app on the phone in a patient wearing the G7 sensor. And you can see this is the glucose trend over time. And yes, the glucose is now 6.5, but you can definitely see that it's traveling downward towards the cliff and it's moving awfully quickly. Dexcom has implemented an interesting feature. So it's using predictive algorithms to project where that blood sugar will be. And the algorithm has identified that this patient may have a 3.1 within 20 minutes. So the alarm is going off now, well ahead of that low. And actually, there is some evidence to suggest that when you alert patients and they treat to prevent the low, that actually prevents them from having rebound hyperglycemia that occurs when they treat the low after it's already happened. So actually preventing these lows in this way can actually reduce hyperglycemia. So that's a pretty cool use of CGM sensing technology. Now, CGM also features Bluetooth continuous push of glucose data. So the current generation of Libre 2, Dexcom G7, all linked to cell phones or to dedicated readers by Bluetooth, continuously pushing the blood sugar data. And what that's enabled is alarms. So patients can get notified of lows and highs. And it's also enabled remote telemonitoring. So often when I call my patients in a virtual visit and they're on CGM, I can pull up the LibreView app on the computer, or I can pull up the Dexcom Clarity app, and we can have a look at their blood sugars on the spot and have a good conversation about what to do. The remote telemonitoring also applies to family members. So this is quite common in type 1 diabetes now for the parents to be looking at the blood sugars throughout the day for their young kiddos with type 1 diabetes and to be getting those alarms. But I definitely see a use case for this for older dependent adults who might have trouble managing their own diabetes. Another interesting feature of CGM is that it's enabled alternative measures of glucose control aside from the A1C. So A1C measurements take about 3 months to refresh. That's how long it takes to turn over a red blood cell. So that's very challenging in practice because you change management, you advise the patient to increase their degree of physical activity, and then you have to wait. You have to wait to see the effect of what you've done based on A1C. Whereas CGM-based metrics are refreshed within 2 weeks. And more importantly, CGM-based metrics overcome a key limitation of the A1C. So this is a figure taken from the JDR website, although variations of this figure are widely available everywhere. But these are 3 individuals with the same A1C of 7.0%. This is what you're hoping for. But this individual swings between extreme highs and having low blood sugars with the same A1C, and you just kind of hope that your patient with the 7.0 A1C is not this person. That's completely not reflected by the A1C, but is reflected by CGM-based metrics of overall glucose control. And the most common one that's accepted now is something called the time in range. So this is what time in range looks like. The target range by consensus for CGM is typically 3.9 to 10 millimolar per liter. And time in range is simply the proportion, the percentage of minutes out of the 1,440 minutes you have every day, on average, you spend with a blood sugar in this magic range, 3.9 to 10.0%. We target time in range of 70% for our patients on CGM. And that threshold is chosen because it correlates well with an A1C of 7.0%, so time in range above 70%. And similarly, our target time above range, so with blood sugars above 10, is typically less than 25%. And our target for time below range, so below 3.9 millimolar per liter, is typically less than 5%. Now, you might have older adults or adults who are more frail and higher risk of hypoglycemia. So these are individuals where we might choose a more relaxed A1C target of 8.0 or 8.5%, for example. For these individuals, we also have custom time and range targets. The well-accepted ones are time and range above 50%, time above range less than 50%, and time below range less than 1%, because these individuals' hypoglycemia tends to be very much less well tolerated. Again, these time and range figures are updated essentially with 2 weeks of information. You have updated time and range figures. So within 2 weeks, you can know the effect of starting someone on empagliflozin or the effect of advising someone to increase their physical activity. So that is pretty cool. So let's talk a little bit about the clinical evidence for CGM. The evidence for CGM being effective and safe is probably best established in adults with type 1 diabetes. As of 2022, there were at least 22 trials of CGM in type 1 diabetes involving over 2,000 individuals, comparing CGM to capillary blood glucose monitoring of blood sugars. Again, type 1 diabetes, all these individuals would have been on insulin. The overall meta-analysis estimate of HbA1c impact was 2.5%. So adults started on CGM had 2.5% better A1C at follow-up than individuals who were continued on usual care with capillary blood glucose monitoring, and that was highly statistically significant. It is worth noting that the degree of benefit depends on your baseline A1C. So adults with pretty bad hyperglycemia to begin with had a much higher degree of improvement, and that makes sense. These are individuals who have a lot more that is readily optimized with respect to their insulin management, including the fact that they might just not be doing finger pokes to know what their blood sugars are at any given point in time. Interestingly enough, the severe hypoglycemia, the signal was not statistically significant, although the point estimate is less than 1. You interpret that as you will. But in trials that had the benefit of CGM in both the intervention and the control arm, so you can do a blinded CGM in control patients so that you can actually measure time and range equivalently in both arms, there was consistent finding that CGM improves time in range, reduces time above range, and reduces time below range for adults with diabetes on insulin. And of course, uniformly, individuals on CGM have better satisfaction with their diabetes treatment. For type 2 diabetes, the evidence is a bit more limited. As of this year, there were 12 randomized trials with about 1,200 individual participants. And the mean difference in A1C, it was statistically significant, but on average, it tends to be a lot smaller, so 0.31% only. But again, improved satisfaction and CGM metrics. Now, one big limitation of this evidence base is that there's only 4 trials which featured adults with type 2 diabetes who were not on insulin. So individuals who were only on oral medications or maybe on GLP-1 receptor agonists. Now, this population is important to study separately because A, it actually is the majority of individuals with diabetes aren't taking insulin. And B, these are individuals who, because they're not on insulin, it's not like 3 times a day they look at their blood sugar and they have the opportunity to fiddle with the doses of their medications. So if CGM is going to be effective in someone like this, it's going to be effective because it changes how they eat or how they do their physical activity or other elements of lifestyle self-management. So lifestyle self-management is more heavily weighted in the logic model of how CGM improves clinical outcomes for adults who are not on insulin. And that makes them qualitatively distinct from adults with diabetes who are on insulin. So we felt this was an important population to study specifically. So we performed a randomized trial to do this. We called it the IQ'd trial. And that was a throwback to when the Libre device was intermittently scanned. So there was a time when Libre was not Bluetooth linked, and you actually had to boop, to get your blood glucose levels. So because we started the trial way back when, ISCGM, intermittently scanned CGM, that's how we got to this name IQ'd. Partway through the trial, of course, Libre became a real-time CGM device. But the name stuck, so the IQ'd trial. The objective of this trial was to establish the 12-week effectiveness of a 6-week CGM intervention paired with virtual telemonitoring-based individually tailored diabetes education. That's a mouthful. All right, let me tell you what that means. Okay, we'll go through the PICOS question here. The population we enrolled, adults with type 2 diabetes not on insulin with A1C greater than 7.0%, so adults with hyperglycemia. No CGM use in the last 6 months. Our recruitment was actually primarily through Facebook ads posted in select clinics, and we even had a global news spot. We did ask providers. We went to a number of clinics to get providers to send us patients, and it was quite rare that we actually had referrals directly from providers. Most of the time, patients saw our ads somewhere and actually called in or emailed in to be part of the trial. So that's really important when we think about who's in the trial and how generalizable these results might be to the people we see every day. The intervention, so folks randomized to the intervention group received 3 Libre 2 CGM sensors. Each sensor has a wear time of 2 weeks, so that gives us a total of 6 weeks of CGM coverage. And then the second part of the intervention was they saw Tanya. They had Tanya time. And that Tanya time was 2 sessions done virtually, the first one between weeks 1 and 2, and the second one during weeks 5 and 6. These virtual visits were enabled with remote telemonitoring. So what that really means was during the baseline randomization visit, we linked up all the sensors to patients' phones and then linked those up to the cloud-based LibreView portal. And then Tanya could access LibreView and see all the CGM data during her visit. So that was really important. The comparator was enhanced usual care. So usual care means no Libre. Some of these individuals were finger poking their blood sugars, but no one was doing it on a consistent daily basis. But the enhanced part is they did have Tanya time. So they had virtual diabetes education sessions. Again, session 1 during weeks 1 and 2, session 2 during weeks 5 and 6. Our primary outcome was the change in A1C from baseline to 12 weeks. Our secondary outcomes were other clinical measurements and patient-reported outcomes. We measured diabetes distress using the Problem Area and Diabetes questionnaire, for example. We measured diabetes-related self-efficacy, satisfaction, health status, diet, and physical activity. This is the trial flow diagram. We screened 227 individuals for eligibility. This is the formal screening. There was an informal screening where sometimes it was quite obvious from an email that someone wasn't going to qualify. The most common reason for exclusion was that patients actually tried to be part of the trial with screening A1C less than 7.0%. I think many individuals were actually just keen to try to get Libre sensors covered. And then a number of individuals didn't consent to move forward. We ended up randomizing 105 individuals 1-to-1 using a computerized system to CGM and enhanced usual care. And then at follow-up, we had about 20% lost to follow-up, so 80% of our study population remained available for analysis. At the 12-week mark. These are their characteristics. The characteristics of randomized individuals. The average age was about 57 years, evenly split between men and women. If you look through this table, you'll see there are some numeric imbalances. CKD, for example, this is probably a feature of small numbers. I think overall balance is reasonable, and that's because if you look at some certain important metrics, like the clinical metrics, like intensity of diabetes therapy, so here's the total number of non-insulin anti-hyperglycemic agents, SGLT2 inhibitor use, sulfonylurea use, GLP-1 receptor agonist used. On these numbers, actually it looks pretty well balanced. It's a bit hard with only 105 individuals. Here's what we found. Here are the results. At baseline, the average A1C was about 8.0%. So sorry, a bit busy slide. This is right out of the paper. On this side is A1C using percent units. This side is A1C using international, mole per millimolar units. Anyways, baseline A1C was about 8.0% on average. In the CGM arm, there was a 0.69% improvement in A1C at 12 weeks. In enhanced usual care, there was a 0.33% improvement in A1C at 12 weeks. When we adjusted for baseline A1C, so recognizing that baseline A1C showed a range in either group, and we adjusted for that, we found that the adjusted difference in change in A1C between groups was actually 0.65% favoring CGM. So on an adjusted basis, individuals randomized to CGM had a 0.65% better improvement in their A1C than individuals randomized to enhanced usual care. And that was statistically significant with a p-value of 0.008. Now we slice the data in a slightly different way. This is looking at the proportion of individuals. So this is the responder analysis. The proportion of individuals with a 0.5% or greater improvement in HbA1c, 0.5% being what most of us would consider to be clinically significant. And we found that proportion was 60% for individuals randomized to CGM and 37% for individuals randomized to enhanced usual care. So we almost doubled the proportion of individuals who were able to achieve a 0.5 or better % improvement in A1C. We found a signal for weight. Folks in the CGM arm lost on average 2 kilos more than folks in enhanced usual care, but no real difference in blood pressure changes in either group. On our secondary outcomes, on the patient-reported outcomes, there was definitely improved treatment satisfaction. Diabetes distress was lower at 6 and 12 weeks in CGM participants, and there was better diabetes-related self-efficacy at 6 weeks, although not statistically significant at 12 weeks in CGM participants. And the magnitude of the differences we detected would be classified roughly as small to moderate based on statistical criteria. We did see a signal for vigorous physical activity. Individuals randomized to CGM increased their vigorous physical minutes of activity per week, more than individuals randomized to enhanced usual care. And that was significant at 6 weeks, although not at 12 weeks. We do find these data a bit difficult to interpret. They're possibly prone to outliers. And there was baseline imbalance in moderate physical activity minutes. So this is a little bit trickier to interpret. And we didn't see any obvious differences on our diet instrument, although admittedly, our diet instrument, well, if you have questions about that, it perhaps was not the best instrument. Now, CGM metrics, this is getting exploratory now. Of course, we have CGM metrics like time and range for individuals randomized to CGM. Unfortunately, we don't have equivalent CGM metrics for the control arm or at baseline. And some trials do this by running blinded CGM. So you can stick a CGM on someone where they can't actually see the blood sugar. But that way there's still a control patient, but then you can actually have time and range and compare time and range between the two arms. And so we weren't able to do that. We only have CGM metrics after intervention participants started the CGM. But, interestingly enough, even by weeks 1 and 2, the GMI, so GMI is an estimate of what the sensor and the app thinks the A1C would be based on the last 2 weeks of CGM data. It's not the same as the venous blood A1C, but actually in stable patients, in clinic, I have found it to be quite similar. So based on the 2 weeks, weeks 1 and 2 worth of CGM data, LibreView thought the average A1C would have been 5.9%. That's much lower than the 8% baseline venous blood A1C that we picked up. So to us, this suggests that the benefit of CGM might be maximal right up front, with people identifying things to change in their lifestyle, their diet, physical activity. And by weeks 5 to 6, the GMI had actually increased to 6.7%. So that's still way better than the 8% blood venous baseline A1C. But it does leave you wondering whether whether the lifestyle changes made in 1 and 2 are necessarily sustainable, or B, whether the effect of novelty could have worn off, right? So there's some interesting things to explore in future work coming out of some of these data. Okay, strengths and limitations of the trial. One strength is that we had an explicit virtual care component, which is kind of relevant post-COVID, right? Some of the limitations of the trial, we were only able to afford 6 weeks of CGM. So you're on CGM, then you were off, and then we measured an A1C. So it's, might be a little bit muddled there. Whether the impact of, whether that last A1C could have been diluted by, 6 weeks off of CGM. We had limited duration of follow-up, so it's a 12-week A1C. I'd be very curious to know if patients at 6 months continue to have better A1C, having been exposed to CGM. And then we didn't have an active comparator, but having said that, in adults with type 2 diabetes not on insulin, it's probably not standard of care for all of them to be finger poking themselves all the time for blood sugars anyways. That might not necessarily be a limitation. From the trial, just to summarize this a little bit here, we found that a 6-week CGM intervention paired with educator visits and telemonitoring reduced A1C by 0.65% more than enhanced usual care with the educator visits only. And it's worth reflecting 0.65% is actually pretty close to the blood sugar lowering effect of empagliflozin in the original glucose lowering trials. So, it's as good as starting someone on a new medication, at least in the short term. And it's not an extra pill for people to swallow. So we concluded that CGM telemonitoring as part of virtual diabetes education should be considered as a non-drug treatment option for adults with type 2 diabetes not on insulin. In terms of practice, if you have someone with diabetes on insulin, you should know that CGM is effective and safe. It is likely to be covered soon for adults with multiple daily insulin doses, and that's based on it being covered in Ontario, BC, by First Nations and Inuit Health Branch. So hopefully it is covered soon in Alberta for individuals on insulin. And if it does, it will, I think, soon become standard of care for your patients. If you have an individual with diabetes who's not on insulin, CGM is been shown to be effective, although the specific dose and frequency of CGM that maximizes effectiveness is not quite pinned down. It's not covered by most insurers for this basis, but it should still be considered in part because I think it's what a lot of patients would want. Okay, let's get a little practical now. Implementing CGM in your practice. I'm going to start by introducing the ambulatory glucose report and going through the components of it, and then showing you an approach to interpreting it. And then Tanya's going to come up and go through some cases with us. So this is the ambulatory glucose report. This is a standardized reporting format that's well accepted by a number of guideline committees. And most manufacturers produce a report that looks fairly similar to this. Right up top, you have some sensor wear statistics. And the goal is, when you're interpreting a report like this, to ensure that there's 14 days of sensor wear with over 70% data capture. So that's reflected numerically here, but you can also look at that at a glance using the daily glucose profile. If there's less than 70% capture, you just see a lot of gaps in the data. So this is a nice at a glance way to know that your data are good. This section here is time and range. We've already talked about what that all means. There's your glucose management indicator right there. So this individual, this is from the LibreView app. This individual LibreView, based on the last 2 weeks worth of data, would project an A1C of 6.9%. The coefficient of variation right here is an indicator of how much spread there is around the mean. We typically target variation of less than 35%. So 35% and above indicates that there might be high variation times where you can talk to patients about a reliable taking of medications or meal variation, these sorts of things. This is the ambulatory glucose profile, a nice visual depiction of where blood sugars tend to fall during any given time of day. The dark line here, you have the median. So at 12 o'clock, the median blood sugar over the last 2 weeks was right there, so 11 maybe. And then the darker blue area, shaded area, is the interquartile range, the 25th to 75th percentile of blood sugar measurements at that particular time of day. And then the light blue shaded area is the 5th to 95th percentile, and measurements below the 5th and above the 95th percentile are simply truncated. You just don't see them on this particular display. And then these are the daily glucose profiles. So this is what the spaghetti line of glucose looks like at a glance. Now, this is pretty tiny, and this mirrors what people see on their phones, actually, because the phones are pretty compressed screen when you try to look at this stuff. And the side effect of that is when you're looking at it on a display that's this shortened, you know, glycemic excursions, highs and lows look extremely dramatic. This is kind of panic-inducing, and I don't find to be the most useful display. And I warn patients, when they try to interpret their phones, everything looks very dramatic. I much prefer pulling it up on the monitor on LibreView or printing off the report and then looking at the daily log. So this is what a daily log looks like. This is really nice. It tracks their sugars for sure, but it also provides individuals with opportunities to enter data. So this individual's been entering data. You know, you can see when and how much basal insulin they took. Okay, I'm not sure why they're taking their basal insulin at 2 in the morning. I hope this is Degludec. I suspect this is Degludec. Maybe this is a shift worker. Okay. And then you can see their bolus insulin dosing. Yeah, I bet you they came home from a shift or something. They took it at bedtime and they slept in until 4 p.m. Anyways. This is their bolus insulin, and this patient's carb counting, actually. So actually the grams of carbs they've entered, but you can write notes on what you ate and when you ate. So if you have patients that are really getting into it, I mean, this is just a wealth of information, and they don't have to do it all the time either, right? Like, hey, give me 3 days where you just enter in as much as you can, and we'll go from there, right? That's kind of nifty. Most manufacturers will have additional pages that vary from report to report. And that's just an attempt to display data in a way that helps users develop actionable insights. So this is one from LibreView called Mealtime Patterns. All it does is it looks at the morning, midday, and evening blood sugars, and then also displays the blood sugars after meals. And it just lets users see how, you know, what their meals are doing to their blood sugars or how good their prandial insulin dosing is at a glance. So these sorts of things are kind of cool. This is an algorithm that's commonly recommended to approach ambulatory glucose profiles. So step 1, ensure your data are good. You're looking for 14 days of sensor wear with over 70% data capture before you think we have reliable metrics. Step 2, look for hypoglycemia patterns. And one easy way of doing that might be to check the time below range. Is it less than 4%? That's good. If it's higher than 4%, stop there, investigate it. I would also advise glancing through the daily logs as well to see if there is significant hypoglycemia. Step 3, look for hyperglycemia patterns. And then step 4, assuming hypo and hyperglycemia are pretty good, look at glycemic variability. So you can try to optimize glycemic variability. So this is what a hypoglycemia pattern looks like. This is from a paper in Touch Reviews in Endocrinology that's quite good. It shows you what a hypoglycemia pattern looks like, and then it highlights possible causes of hypoglycemia to explore with patients and potential action items. So it's a nice paper on interpreting CGM. But this is a typical hypoglycemia pattern. This is a hyperglycemia pattern. And then this is a high glycemic variability pattern. So you could see how wide the river is on the AGP at certain times of day. And you might explore things like, oh, are there days where you do shift work, so you're sleeping during this time? Is the weekend different from the weekday in terms of physical activity or what you eat? All right, so that's the ambulatory glucose profile report and an approach to reading. Now, actually, we have a couple of cases, so I'm going to pass it over to Tanya to provide the educator's perspective.
Thanks, Tony. Okay, so as I go through some information, I might be highlighting some stuff that Darren already said, but I'm just talking about it in a way that I might talk to a patient. So as an educator, one of my passions is educating patients to empower them to do their best in their own diabetes care. One part of that is turning CGM data reports into usable information for the patient. So a common thing that I hear from patients is that they appreciate the reports being explained in a way that they understand. So let's take a look at case 1. Here we go. While we look at what a discussion with a patient might look like. So 43-year-old female, hemoglobin A1C 8.3%, medications, Degludec 18 units, Aspart 4 to 6 units with meals, dapagliflozin 10 units once daily. She goes to the gym 5 days a week after work between 16:30 and 18:30, and this patient is wearing a Libre. So I would have patients open their reports on their phone, reader, or in LibreView itself and look at them. If we happen to be talking on the phone, we might review LibreView together in person if we're in the office together. So the first report we look at is time and range. So after explaining the report ranges, we would discuss the patient's numbers, where they're at, along with the goals for each area. Like Darren said, hemoglobin A1C, time and range does not give us the full story, especially if we want to make changes. So we would discuss GMI, compare that to the patient's hemoglobin A1C. I would mention what GMI is looking at, the 2 weeks of information, and explain to the patient that if their blood sugars remain the same for 3 months as they have been over the last 2 weeks, that this is what their new A1C would be around. So they can look at their phone report of estimated A1C as well, but they should pay attention to how many days out of 90 that the report is looking at. The reader does not have an estimated A1C report. An increase of time in range of 10% or 2 hours a day over 3 months equals a 0.5 to 0.8 A1C drop. So that's pretty good. So data captured, like Darren said, at least 70% for a good amount of information on the reports. If the patient is not achieving that, I might talk to them about how to gather more information. So we'd talk about distance of the phone to the sensor, because there's a certain amount of distance where it captures the data. Scanning if needed. So if it just doesn't seem to be picking up, we can still scan with the phones for the Libre, not necessarily the Dexcom. Keeping the app running in the background on the phone is important, so they keep communicating. Turning off automatic operating system updates on the phone, as the new apps need time to update after a new operating system is released. So that can be pretty important as well. Glucose variability. What is the patient's number? Less variability equals better long-term health and quality of life. So how do we improve the numbers? What and where are the problem areas? So I like to look at AGP next. I might explain to a patient something like this. So this report, the AGP report, gathers all the information that your phone has collected over the last 2 weeks, and it puts it all in one spot. Then it draws a line through all the middle blood sugars. So this dark line in the middle is a median line, not an average. This line gives us trending information on how blood sugars move through the days over the last 2 weeks. I would run through the line movement with the patient and just talk about how it's trending. So the overall goal would be a flat median line in the middle of the target range, but let's see if we can start by reducing the bouncing first. The dark blue river is what I call the interquartile range, is 50% of your blood sugars. This shows us what levels most of your blood sugars are moving in from day to day. The wider dark blue river, the more variability you have from day to day during that time frame. So say around 1600, let me find my mouse here. So around 1600 here. And then again at 2100 are the widest areas. And the narrowest areas around 0100 and then also 0600. So a narrow river would be the overall goal. So let's start by getting rid of any low blood sugars first. Second, work on reducing variability. And the way I commonly work on reducing variability before reducing the highs, because I find if there's a bunch of variability going on, sorry guys, if we try and tug down the highs, that can commonly put person into more lows. So that's just the way I like to do things. And then third, we'd reduce the high numbers. So the light blue river here contains 80% of your blood sugars on the phone and 90% on LibreView. So side note, when talking to patients about AGP, the light blue river might look slightly different between the phone and LibreView. The reader only shows the median line and the light blue river in the color of gray, and it does not display interquartile range. So sorry, that's specific to Libre because this person's on it. So back to the patient. The light blue river tells us how high and low your blood sugars are reaching every once in a while. I might explain a little more in depth by giving an example. So at, where's my mouse? There we go. No, 2100 here. The median line is up. The interquartile range is completely over 10, not touching the target range line, indicating that your blood sugar is over target about 70 to 80% of the time. The light blue river reaches down to the mid-target range, about 7 millimoles. So this has probably happened once in the past 2 weeks. So some other information we can pull out of this patient's AGP. Overnight blood sugars trending down with the likelihood of some reaching into low blood sugars, keeping in mind that there are some blood sugars below the light blue river that this report does not capture. So low blood sugars don't seem to be a big deal through the rest of the day. And highest variability after second and third meals. So high blood sugars, that's pretty much elevated all day, but the biggest problem area seems to be after supper, after the gym, before bed. There we go. So moving on to the daily log report. This report is only found in LibreView. We cannot access this on the phone or the reader. So I use daily log to confirm AGP and pull out more information. We find confirming that low blood sugars are, this does confirm that low blood sugars are occurring overnight. So the patient is sometimes overtreating their low blood sugars and bouncing them back up high. There is variability around the time that she is going to the gym. So we're looking around this time here. And then bolus timings, at time the patient is looking at her phone. So here we can see these dots. So when the patient is looking at the phone, and then also here, after the blood sugar is already rising. Is there a possibility of late bolusing? So questions I would be triggered to ask. When is the last dose of rapid in the evening? Has there been any correcting? Having a snack without a bolus in the evening? Trying to avoid overnight low blood sugars? When is supper? When are boluses being taken in relation to the meals? Are we forgetting to bolus? Carbohydrate loading before exercise? Reducing or missing lunch rapid before exercise? What types of exercise? Continued discussion on possible causes of evening rise. So if we're not looking at LibreView, I would encourage patients to look at the 8-hour line graph with each blood sugar viewing on the phone, because that tells us a lot of information about what's been happening. An increase of 2 hours of time in range could be possibly reducing the low blood sugars, and the bounce back up to high could be reducing sugars after 1 meal per day. So it doesn't seem like much. So just some takeaway tips. Patients' ability to pull information will allow them to make changes when they are needed or wanted. Is the patient using a reader or a phone? What is their level of comprehension? Readiness to learn? What are their medications? All of this may dictate where we are starting from and how deep we dive in. So daily log is great for seeing immediate results after making a change, triggering questions to ask, and pulling out more information. Reviewing blood sugars frequently can help a person recognize problematic patterns.
Thanks for that, Tanya.
Hmm.
Before we go to case 2, case 1, I don't know if members of the audience had any thoughts on these patterns. Does anybody, I'm afraid I can't, I don't know if I can poll the folks on online, but any thoughts? Okay, sure. Any thoughts in the room? If you're in the Department of Endocrinology, you're forbidden from answering.
I would just say over basalization. I think it's a common problem, but I feel it's always what learners go to when things are too high, and it's usually the opposite. We don't actually have enough very rapid acting.
Yeah, CGM is fantastic for showing the overnight trend in blood sugars that can be a big indicator of what's happening there. When you see the blood sugars fall down like this, you do worry. And this is clearly a patient with type 1 diabetes. They're not on that much insulin, and they have this kind of response. Yeah. I think this is also a good example of, we thought this was a good example of potentially feeding the insulin. An individual, if you look at how high the variability and how much hyperglycemia there is after the patient goes to bed, yet down goes the blood sugars overnight. So there's a high possibility this individual knows they're going to run low overnight and is driving their blood sugars up by snacking before bed. So that comes up very clearly, I think, in these pictures. All of these are hypotheses. You know, the CGM data is so good for generating hypotheses, but it's that connection with the patient you make, you confirm hypotheses, you develop, you know, course of action to see if it makes things look better the next time you look at the CGM. That's really enabled with charts like this. The other thing that stands out strongly from this particular set of CGM data is the practices around exercise. 2 out of the days here, you can see, so on the Monday and the Tuesday, that sharp rise up in blood sugars after about 2 p.m. But you don't see it on the Thursday or the Friday. It's relatively flat. Actually, Thursday and Friday were fantastic afternoons for this patient. And so you also wonder, are these days where she was at the gym, did she know she was going to go to the gym, was worried about lows, and then overdid the carbs or underdid the insulin, right? So, you know, that's the variability there indicates that's an area you can really focus on and chat with individuals about. And I like that you can pick a certain problem area and you just pick one thing to focus on for the visit and then check back on it the next time, right? It's all about, what was it, SMART acronym? I forget what it stands for now. Manageable, right? Like your action items have to be small, manageable, you know, etc. I'm not an education person, clearly. Okay, here's case 2. Okay, we won't belabor this, but this is an interesting case where there was a real disjunction between what the CGM showed and what the blood venous A1C showed. So this is a 79-year-old male that I saw in practice. The reason for referral was high insulin doses, but despite high insulin doses, the A1C was 9.6%. The patient had been prescribed Basaglar, 50 units in the evening, had been prescribed Aspart, 30 units, 3 times a day with meals. There was a recent increase just before I saw this patient of semaglutide from 0.25 to 0.5 milligrams. Semaglutide is Ozempic. And this patient, despite being on 50 units of Basaglar, 30 units of Aspart, was not routinely checking their blood sugars by finger stick. I had no idea what the finger stick blood sugars actually were because the patient simply wasn't doing them. So I started the patient on a Libre 2, and 4 weeks later, we come back to clinic, and this is the LibreView report. Holy moly, that GMI is 6.9%. What is happening here? The blood venous A1C was 9.6%. This wasn't too long ago. Time in target range was 68%. Time below range was 4%. And remember, this is a 79-year-old individual. Like, this is an individual for whom our target range should actually be 50%, and our time below range should be 0, right? Like, I'm not willing to accept any time below range in a 79-year-old individual. And so 4% time below range is actually on average 1 hour out of every day. You know, on average, 1 hour of it every day spent with time below range, because 4% is almost 1/20th, 24 hours in a day, right? So that is a lot of cumulative time below range. What is happening here? How do we come to results that are so different from the blood venous A1C? So here's the AGP. We can absorb that. And I'm going to show you the daily logs. Here's the daily logs. Oh, a little mini heart attack in clinics. Like, wow, what is happening here? Whew. I'm going to give everyone a moment to absorb these data. This is an interesting case. This is an interesting case. Okay. Yeah, I sure can. He was noticing these lows. But he didn't report lows before. When I talked with him in our first visit, he had no problem. Doc, my diabetes is going fine, right? No symptoms of lows, despite not checking, right? But he was feeling it now, and he was getting alarms. That was one thing he was noticing, was this phone is beeping a lot. It's telling me things, right? I'm gonna get Tanya's opinion next, but before we do that, any thoughts? Any other thoughts from the room? Any other thoughts from Zoom? Okay. What do you think, Tanya? What were your thoughts when you saw this? This is a patient I sent to Tanya.
So it's interesting when someone gets on CGM and they see what's actually happening. It could be some accountability of what they're, you know, the difference between what they're actually doing and what they thought they were doing before. You know, he's maybe seeing a lot higher blood sugars. Was he actually taking 30 units of insulin before, or was that just what he was reporting? But when it's kind of thrown into your face like this and you're seeing what's going on, maybe when the first day he started and he saw what happens when I don't take my insulin, if that's what was going on, right? Oh, wow, look at this blood sugar. I better start taking my insulin. And if you notice right here, when he recorded his insulin, how much he was taking, it was 10 units versus that 30, right? So what was really going on? So I think CGM is just really neat in letting people know. So that's awesome.
Yeah, I had the same thought. The tip-off was the one time he recorded his insulin dose. The one time he recorded it, it was tiny compared to what he was prescribed. And it showed a higher degree of insulin sensitivity than I would have expected based on his doses. I think he was not compliant with his insulin to begin with. But once he got on his CGM, he was starting to get alarms, and he actually knew his blood sugars, and he started taking his insulin. Oh my God, he started taking his insulin. So this was this is one example of where I don't see many examples, and CGM is safe in the trials, does not increase the risk of hypos, does not increase diabetes-related anxiety, but this is one actual instance where I think starting a CGM might have been harmful. So it's something to watch out for. No, maybe not, because he did get things under control and his blood sugars were much better on lower amounts of insulin afterwards with CGM.
And then we had a truer picture.
Okay. Anyways, there are other hypotheses as to what could have happened here, but I am going to stop there on this conclusion slide because it is time for questions.
Perfect. Yeah, so we do have 5 minutes for questions. Can I just kick it off? I want to go back to your trial. I mean, I know, small numbers, but what an impactful trial in terms of, we talk about lifestyle interventions a lot, but we don't see the outcomes. And you showed very nicely, the old inequality we talk about, when you know better, you do better. And so with CGM, I think there was some of that translated. But what do you think was responsible for the reduction in response between 6 and 12 weeks? Do you think it was the fact that you stopped the CGM, or was it just, we start with the best of intentions and then, we can't continue it on?
I wish I could tell you. I want dollars for a bigger trial to actually look further and see. I mean, it could be that the novelty is worn off, and these are individuals who are not on insulin, so they're not having something to adjust from a day-to-day basis. So it's about sustaining lifestyle changes, and we know that lifestyle changes are actually pretty hard to sustain. But it could also have been that they had 6 weeks off of the CGM, and this is my personal opinion, but I do believe that the ideal use case for somebody like this might be intermittent or episodic use of CGM as a refresher every now and then, just to get people back on the bandwagon with physical activity and diet changes that they might have started with when they first picked up CGM.
Or alternatively, lobbying to insurance carriers that this might be a good indication for when to support CGM, in terms of preventive health and targeting lifestyle and so on.
If you think of the $90 cost of a CGM sensor, and let's say you use CGM half the time, so once a month, that is the same cost as a prescription for empagliflozin with a similar upfront A1C reduction.
But EMPA would lower your blood pressure too.
That's true. That's true.
Yeah.
Go ahead, Prala.
Just when you were recruiting for this, I was wondering why you chose type 2 diabetics not on insulin for CGM, when our recommendation when they're only on oral hypoglycemic agents is to not check as frequently. Can you explain why?
Yeah. That recommendation is because finger stick blood sugars are not shown to be cost effective or necessarily effective in adults with type 2 diabetes not on insulin. There's a variable amount of evidence there. But the big barrier is that they have to stick their fingers. And when you have something that lets you check your blood sugars at a glance, reduces that barrier, I think individuals are much more likely to be able to mobilize that information for lifestyle changes. So I think CGM qualitatively is a very different technology than capillary blood glucose for measurement. And the open question that we were looking at was, capillary blood glucose probably not sustainable long-term on a regular basis, but CGM, will it make a difference here?
There is 1 more minute, and if there's no questions Ross?
Ross, thank you for your support for this trial.
Oh, no, my pleasure. So I can't remember if we talked about this during the design part, but you didn't use a like a sham sensor. Do you think that had much impact? So in the enhanced usual care group, they didn't have a sensor.
Yep.
Do you think that had an impact on the results?
Yeah, I would have loved to have had the funding for that so we could have comparable CGM metrics in either group. I presume you mean a sham sensor is in a real sensor that's giving us data, but they
But
can't
not-
see
yeah,
the data.
not being
so
fed
they're
back.
blinded to it. Yeah.
Yeah.
I mean, that would have been ideal. But on the other hand, if we were to use this in real life, I don't. Yeah, I think perhaps without the sham sensor, we have somewhat more realistic comparator.
Yeah, I don't know, because on one hand, part of the value of this is the patient being able to see it. And so does the disconnected sensor really have any impact? Like if I didn't see the results, it probably wouldn't affect what I did day to day.
Yeah,
So,
to be fair, you know, thinking from it both sides, you know, just having a sensor on and knowing that you're being monitored might produce an impetus for. So I can't exclude the
Maybe, yeah.
possibility that the magic sauce might actually just be the sense that someone's looking at you.
Yeah, three groups, right? The Libre group monitored, non-monitored.
Yep.
And then the other group.
Yeah,
But
maybe,
That's great,
yeah.
thank you.
Maybe we need to prescribe placebo sensors instead of
Yeah.
the sensor. It costs a quarter as much.
Really fascinating study, and yeah, I'm optimistic that you will get some money to do a bigger study, because I think this is really important stuff in terms of, you know, you've obviously shown the importance we know the importance in type 1 and in insulin using type 2, but I mean, there's just such huge preventive health opportunity here as well that is untapped, I think. So on behalf of the department, thank you. And thank you, Tanya, for visiting, and good luck with your future endeavors in this. Okay.